All right, this first set of homework video is just the 9 slides that it bridges you to the main video, which goes through the rest of this chapter. The second video that you'll see that goes through the rest of this chapter was pre-recorded last semester. So ignore the part where it says we're starting the biomechanical packet on Monday. We'll be starting the first packet of the lower extremity on Monday. You have a quiz on Monday again, which is on this packet that we're finishing today in lecture. It does not contain questions from packet 5. And then, of course, your first or your second exam on the upper extremity will take place on Wednesday. All right, so bridging the gap here, we left off at the slide previous to this. We were talking about the carpal, metacarpal, and intermetacarpal joints. So again, to refresh your memory, carpal, metacarpal is between the base of the metacarpals with where it meets the proximal row of carpal bones. So the base of the metacarpal is where it meets the proximal row of carpal bones, with the exception of the thumb. That's still a carpal metacarpal joint, but it's kind of its own thing because it's our only example, of course, of a saddle joint. So the first carpal metacarpal joint on its own island as a saddle joint. The digits 2 through 5 carpal metacarpal joints, where they have the base of the metacarpals meet the proximal row of carpal bones. Those are going to be great examples of purely just a sliding joint for the most part, or gliding joint. All of the joints in question, including the intermetacarpal joints. So remember, joints are always going to run vertically. So these are running the joints that are going to run vertically between where the metacarpal joints of digits 2 through 5 are interacting or sliding against each other. And remember, they're all examples of diarthrodial joints, even the first carpal metacarpal joint. So of course, they're going to all have joint capsules because that is quintessential to be called a diarthrodial joint, right? That's part of the process. So if we look at the radiocarpal joints, so again, technically speaking, the radiocarpal joint is just going to be between the distal end of the radius, where it meets your scaphoid and your lunate bones of the wrist, which is in the proximal row of wrist bones. If you have dislocation in some people's anatomy, they may have the triquetral bone that also kind of articulates in there, but they shouldn't. It should just be the scaphoid and the lunate that make contact with the distal end of the radius. Relatively stable joint for the wrist because of the fact that it's bounded in all 4 directions by ligaments. So of course you've got the volar and dorsal radiocarpal ligaments, which are a transverse ligament. They go across from medial to lateral on both sides of the wrist, anterior and posterior. And then of course you've got bounding on the sides of either wrist, both medially and laterally, with the ulnar or medial collateral ligament and the radial or lateral collateral ligament. Now, in terms of blood or nerve supply, the good news is for the hand, it's straightforward. Unlike the wrist or the forearm, where, you know, extensors were pretty much all radial and that was an expected kind of thing, the nerves follow the distribution pattern we would expect for the hand. So of course, the thumb being the first digit, that is supplied exclusively by the C6 nerve root, aka the radial nerve. C7 nerve root is going to take care of the index finger and the middle finger, which is going to be the median nerve. So that is where we'll see symptoms for carpal tunnel extend into those 2 fingers. And then the C8 nerve root, which is going to be of the ulnar distribution pattern, will take care of the 4th and 5th digit. So very common to what we would expect in terms of where those things are laid out. Now, the ulnar and radial nerves, not the median nerve, give rise to what's called your deep and superficial palmar arches. So one is close to the surface, one is not. One is supplied by the radial nerve, one is supplied by the ulnar nerve, and they form exactly as the name implies, an arc over the palm of the hand. And from that superficial and deep palmar arches, you will have the branches for arteries and nerves that go to all of the individual digits for feeling, sensation, and blood supply. Now, the next unit we're going to look at is musculotendinous injuries of the hand. These are a couple of the things that we're going to see in that distribution pattern. Notice that most of these are going to be, with the exception of tendon laceration, which is a traumatic event, the first 4 are caused by repetitious use injuries, inflammatory conditions, things that are caused by day-to-day wear and tear, or repetitive injury that we take on a new sport and we're not giving ourselves the proper break needed kind of situation. But those are all going to be, at the end of the day, an inflammatory issue, with the exception of that tendon laceration. So again, what is the best way to treat any inflammatory issue is to let it rest, decrease the inflammation. That's our first and foremost focus, right? Is we want to get that inflammation down. So put the patient on rest from whatever joint is being inflamed. What you consider a rest period and what they consider a rest period are usually going to be at vastly different ends of the spectrum, because especially if it's a repetitive work injury, they can't miss work. I need a paycheck. I need to pay for my family, kind of thing. So it's going to be really hard to get them to be really compliant with this stage. And you just have to explain to them, do you want to take off, 6 weeks now or 4 weeks now of altered use? Or do you want to just do what you want to do, and then you're going to have a permanent injury that causes disability? And then what do you do? So you really have to kind of talk them into reality and say, look, I know it's inconvenient. It's never convenient to have an injury. It's never convenient to have pain, but we got to deal with this correctly the first time, or it's going to be a multiple time event, and or it can result in a permanent injury down the road and disability. And they usually are scared by those words, and hopefully they'll better understand what you're trying to do for them. So if you have a not so compliant patient, then that's where occasional bracing and splinting will really come into play, because if they're going to do what they're going to do, no matter what you tell them, then we got to make them do it more efficiently with less injury or less assault to the previous injury. So bracing and splinting work great for when they're doing the assaultive activities, but you have to remind them that when they're resting at home at night, or when they're for sure sleeping, that they want to take that brace and splint off, because it is part of the healing process to let that area swell. That's how it heals itself to some extent too. So wear it while they need to do the activities that they need to do, but then remove it when they're not doing those activities. Inflammation control is your primary thing for the acute stage, which can last up to a week, and that's going to be where you're using things like ibuprofen to decrease inflammation, cryotherapy, aka simple as putting an ice pack on, or going to cryotherapy facilities where they do specific cryotherapy over the area of inflammation. Friction massages are great tools that we've kind of really started to adhere to in the last decade or so. Friction massages are things that are, I know we hear the word massage and we think, relaxation. This is anything but a relaxing massage. This is almost a torturous massage. So I use a thing called a scraping tool. It's called Graston technique. It looks like a butter knife almost. And you literally will scrape the layers of fascial adhesions where the tendon and the skin are beginning to adhere to one another. It greatly frees up range of motion. It helps with bringing blood flow to the area, because that's important. Tendons typically don't have a great supply of blood. So anything we can do to encourage blood flow to the area helps extend or help speed up that healing process. But it is definitely what I call a Tourette's massage with my patients. I always say we're not doing it right unless you're going to sit here and go, ooh, ouch, that really hurts. That's part of the friction massage. So it's not something that's relaxing by any means, but it definitely is a tool that helps, especially for people that are otherwise non-compliant with the rest portion of things. Once you've got a handle on the inflammation, and I really wouldn't cross this stuff until you've got a handle on the inflammation, then and only then should you start thinking about the therapeutic exercises. Stretching, strengthening those areas, learning to do things biomechanically in a different motion so as not to re-injure those areas. That's what we want to concentrate on, but only after the inflammation stage is under control. Because if you add that component while you still have inflammation, you're going to make everything worse, and then the patient's going to hurt more. And then, of course, if they hurt more, they don't want to do what you told them to do. So it's kind of a downward spiral from there. So we have a couple different tests that test for different things. I have videos in your slides, so I encourage you to watch those videos. I'm just not going to play them in the middle of lecture. But there are slides, I think it's like 2 slides down, where it says orthopedic test of the forearm or wrist. So definitely these are all shown you in there: Finkelstein's, Tinel's, Phelan's test. So Finkelstein's is a test for de Quervain syndrome. De Quervain syndrome typically affects the carpal tunnel area. And so the athlete will take, or the person, doesn't have to be an athlete, will take their thumb and tuck it underneath their other fingers when making a fist. So everything, whoever taught you how to make your first fist, everything they told you not to do, but in this case, we're not punching somebody with our fist, so it doesn't matter. We're not going to break our thumb. So we want to tuck that thumb and tuck our other fingers 2 through 5 over the thumb. And then while we're in that fist position with our thumb tucked inside, they're going to ulnar deviate. So they're going to deviate towards their ulnar side. Doesn't matter if they're in an anatomical position or not. And if they get increasing pain over the carpal tunnel distribution, which is right on the anterior volar surface of their carpal bones and into those 2nd and 3rd digits, that will be a positive sign indicating stenosing, I can't even talk this morning, sorry, tenosynovitis. So inflammation of the synovial membrane that encloses the tendons has narrowed. And so when you ulnar deviate, it clamps down on that little synovial membrane that's over the tendons for most of your extensor or flexor tendons for your fingers, and that will cause an increased sense of pain in that distribution pattern. Tinel's sign is also a great one for carpal tunnel. Again, these are rudimentary orthopedic tests, but they pretty much have a fairly accurate involvement in terms of if we have a positive test for Tinel's and Finkelstein's, we can probably guarantee that the required issue like carpal tunnel is indicated by having positive exams. So Tinel's sign, you're going to have the patient have their hand at rest. You're going to maybe have them slightly extend their wrist, and then you're going to tap with 2 fingers in a percussive motion over the volar surface of the carpal bones. This tapping for an extended period of time should cause paresthesia, aka tingling and numbness, over the area you're tapping and into their 2nd and 3rd digit. And again, that's the distribution pattern for the median nerve. And that increase in paresthesia, tingling, and numbness is indicative of a positive sign of carpal tunnel syndrome. So again, just showing you Finkelstein's test. Again, we're going to tuck that thumb in, and then we're going to have them ulnar deviate, so towards their pinky. And again, that could cause pain right here over the thumb distribution, as well as they might have medial pain over the median nerve distribution. But the tenosynovitis is this tendon right here that supplies flexor pollicis brevis and flexor pollicis longus. So essentially that, when you deviate this way, that causes extreme tension here, and your pain distribution pattern will be over the base of your first metacarpal. Now with carpal tunnel syndrome and the Tinel sign, again, have them hyperextend or just slightly extend the wrist. You're going to use 1 or 2, I was always taught to use 2 fingers over the medial nerve distribution, median nerve distribution. And again, that repeated tapping should cause their fingers in the 2nd and 3rd digit, as well as the actual area where you're tapping over there, to start to become numb or tingling. Phelan's test, it looks like we call it the reverse praying sign. So instead of making a prayer sign, you're going to go reverse wise. So you're causing extreme flexion of the wrist. Again, holding it in this position for approximately 1 minute. If it causes pain over the median nerve distribution on the anterior wrist, as well as into that 2nd and 3rd digit, that is positive for carpal tunnel syndrome. So again, make sure you watch the videos associated with all of these tests, which is on the next slide. The other one we can do, and this can be done at any joint. It can be done at the wrist joint. It can be done at the proximal or distal interphalangeal joints. These are going to test your collateral ligaments, so medial and lateral collateral ligaments. So in the case of the wrist, the radial and ulnar collateral ligaments. In the case of the fingers, it'll be your medial and lateral collateral ligaments. So we use this test. So what we're going to do is stabilize the wrist. You're going to hold the wrist firmly with one hand and allow no other movements at the wrist with your left hand, as you see in the left picture. And then he's going to take his right hand and bring the wrist into extreme ulnar and extreme radial deviation. And then depending on which side has pain, with that passive range of motion to that extreme deviation of radial and lateral, that will indicate whether we have a varus or a valgus collateral test issue. If we do the same thing with the wrist, where we stabilize the wrist and now we're going to bring it into extreme extension and flexion, that's what we call the anterior and posterior glide test. Now again, these can be done at the finger level. You would stabilize the joint, either the distal or the proximal interphalangeal joint, and you would basically laterally flex it from side to side, testing the stability of your 2 collateral ligaments. You could also stabilize the finger joint and then cause the wrist or the finger to go into flexion or extension. So those are all going to be seen on these orthopedic wrist exam videos that I prompted you for. So definitely take a break here, pause it, watch those, so you make sure you have a good idea of what those tests look like and what they're testing for. This is where your second video will pick up. So now I encourage you to stop, look at those orthopedic tests, and start video 2.